Okay, we will go ahead and get started. Good afternoon, everyone, and thank you for joining us today for our chronic disease management work group. Chelsea Andrews and I are the site engagement coordinators for MVC, and we look forward to facilitating this work group today. So today's work group will feature a presentation by Jessica Ramsay of Gleaners Community Food Bank of Southeastern Michigan, an organization with a mission to provide households with efficient access to sufficient nutritious food and related resources. Jessica Ramsay currently serves as the Director of Wellness and Nutrition Education at Gleaners Community Food Bank of Southeastern Michigan, where she leads the organization's healthcare strategy and oversees and supports all nutrition education programming provided throughout Southeast Michigan. Her 15-year career in public health to date has centered around a combination of community-based research, program management, and education, all with the goal of reducing health disparities faced by marginalized communities. Thank you, Jessica, for joining us today for this work group. Before you begin your presentation, I have some brief housekeeping items to review. First, as mentioned, the session is being recorded. The slides and the recording will be shared with the attendees following the work group. Next, we will be monitoring the chat throughout the presentation, so please feel free to add questions there. We will also have some designated time at the end of Jessica's presentation for an open Q&A if you'd like to unmute yourself and ask the question then. Lastly, your feedback is very important to us, so if you could please complete the post workgroup survey in a link that will be provided, that would be greatly appreciated. And with that, you are welcome to start your presentation, Jessica. I will advance to your first slide. Thank you so much again for being here with us.
Thank you, Christy, and hello, everyone. It's great to be here. Thank you for having me. I'm always excited to present about the Gleaners and especially the work in the healthcare space that we've been doing. And as you mentioned, my background is in public health. I've spent many years working within the hospital systems on the southwest side of Chicago, and again, focused on chronic disease self-management programs, evaluation, research, and program implementation. So it's interesting, about 2.5 years ago, I pivoted to my role at Gleaners. So definitely my first time coming from the food insecurity and food bank perspective, but really interesting in kind of being on a different, looking through at healthcare partnerships around chronic disease and reduction of health disparities from a different lens. So we can go to the next slide. Great. So today what I'll talk about, I'll give a brief overview of Gleaners. I would imagine some of you are probably familiar with Gleaners, some maybe not as much. So I'll talk about our organization and kind of the overall the work that we do, touch on the direct link between food insecurity and health outcomes, which also I'm sure most of you are familiar with. And then I'll talk about overall Gleaners healthcare partnerships and go into more detail on Henry's Groceries, which is our most recent part and longest partnership with Henry Ford Health System. And I'll end with some lessons learned and kind of what we're looking towards and building towards for the future of our healthcare partnerships. Next slide. Thank you. So Gleaners has been around for over 45 years. And we've been starting off with a focus on Detroit, but gradually expanding over those 45 years to serve what we currently serve as 5 counties in Southeastern Michigan. So those include Wayne, Oakland, Macomb, Monroe, and Livingston. We actually have 4 warehouses. Our largest is in Taylor, which we've been in, I believe it's been about 1.5 years that we moved there to a brand new, larger location. Everything used to be headquartered in Detroit. We do still have our Detroit warehouse, however, and then we also have warehouses in Livingston and Pontiac. So pretty widespread throughout our 5 county service area. And as Christy mentioned before, our overall mission is to provide households with all households, I'll add to, with access to sufficient nutritious food and related resources, meaning nutrition education, food safety, and healthy recipes, for example. So anything related to nutritious food. Our vision is to achieve a hunger-free community in Southeast Michigan. So how do we, oh, you can say on the slide, don't have to, or I'm, yeah, that's fine. I'm kind of in between slides right now. So how do we support this mission and vision? So just to kind of give a sense, and again, some of you may be familiar, we have currently over 60 mobile distributions. So this model of food distribution to communities was really born out of the pandemic and the inability for everyone to go inside and get their food like a grocery store. So we really started to create this mobile distribution model where people could drive up and get the food that they need at, during the pandemic, where they kind of also had a no touch policy at these distributions, where people are able to open their trunks, and those that were working at the food distribution would put their food in and they would drive off. That model has proven to be really popular among clients. So we have continued that post-pandemic. And again, we have 60 mobile distributions. These are at schools, they're at senior centers, they're at other community organization sites run by either volunteers or staffed by Gleaners. And then we also have over 325 stationary, meaning brick and mortar walk-in pantries throughout our 5-county service area. We also have provide comprehensive nutrition education programming for households, and also just kind of working towards the bigger picture around policy, system, and environment change. And specifically, like I'll talk about today, over the past 8 years, our work has really involved direct partnerships with healthcare organizations to kind of expand from all of our mobile distributions and pantry work. Our work is constantly evolving, and we have a community engagement department that is on an ongoing basis assessing the needs of our very diverse communities, and kind of adjusting our models and the resources that we offer accordingly. We can go to the next slide. And this just is briefly kind of consolidating and showing what our key impact areas are. So with the combination of our food distributions and our nutrition education and community engagement, we focus our impact and want to see the most impact around economic benefit. So meaning understanding what the value to each household is of the food that we provide and the other services that we provide. So what economic or monetary value does the food that we provide and the services we provide offset for each family? Secondly, we want to affect stability. So we know that a lot of folks that are food insecure or experiencing food insecurity are often making trade-offs in their house. So for their household. So meaning they might, if they have to purchase food one month or purchase more food for any given reason, that might mean that they can't pay a certain bill, a utility bill, or part of their mortgage or rent, which can affect their overall stability. So what we know is that if we're able to provide stable, ongoing access to food for those who are facing food insecurity, then that can help result in a more stable home environment, meaning that people don't have to move as much. Children can stay in the schools in their communities for a longer term basis. Thirdly, and what we're focusing on today, is health. We want, through the food and nutrition education, we want to be able to improve healthy eating habits and behaviors, reduce the time and expense of treatments, and improve overall health outcomes for the households and in turn the communities that we serve, getting at population health. And finally, empowerment. So with all of these impacts, we hope that and have seen that households have more confidence and can have more and have more time and energy to work on priorities that can help them in the areas of social mobility and just overall quality of life, if they're not so stressed every month about how they're going to get food, how they're going to cook their next meal? How are they going to pay their health care? So that's kind of, it's a domino effect on a longer term around empowerment. And going to the next slide, honing in on the health outcomes. So what do we know about food insecurity and health outcomes? So as you're all probably aware, food insecurity is one of the leading social determinants of health. It has a clear impact on the health of individuals and communities, and that's both for those that's both leading to health issues, the development of health issues, and also affecting the management of ongoing chronic conditions, for example, which we often focus on with food insecurity, meaning people that are food insecure, we know that they have a harder time managing or controlling their existing health conditions. So we know also that food insecurity can lead to development of type 2 diabetes, for example, high blood pressure, heart disease, obesity, asthma in both children and adults. We also know, as a specific data point in the Feeding America Food Bank Network, which is a network of over 200 food banks, we know that more than half of the households in that network that are served through one of the food banks has at least one member living with high blood pressure, and more than 1/3 of those households have a member that has diabetes. So that's just one example of the higher prevalence and just generally high prevalence within food insecure communities specifically. Oftentimes we know, as I mentioned, that there are trade-offs and they focus around health. So families and households needing to choose between food and a treatment for an illness, which can of course cause serious health implications. Children specifically are particularly at more risk of hunger, and more at risk of hunger are more prone to health issues overall and struggle in school. So that's both physical and mental health and behavioral issues. And any family member of any age that faces food insecurity is also in general more likely to struggle with both mental and behavioral health issues. So those are just a few highlights of how we know food insecurity and health outcomes are linked. And this really provides a clear basis, for addressing food insecurity with the goal of improving population health and therefore tying into food bank healthcare partnerships. You can go to the next slide. So over the past 8 years, approximately, Gleaners has had several different types of partnerships with healthcare organizations. So this is everything from clinics to primary care offices federally, and these clinics have primarily been federally qualified health centers. We've participated in a trial around diabetes outcomes that Feeding America led with several different clinics in different areas of the US, and that had partnerships with a local food bank. We've also partnered with foundations and organizations that are implementing evidence-based chronic disease self-management programs, larger healthcare systems, and we've also explored many partnerships with Medicaid managed care and other health insurance organizations that focus on Medicaid and Medicare patients. So like HAP, Meridian, Aetna, Blue Cross Blue Shield, and a lot of these conversations are really taking off, and partnership opportunities are really taking off right before the pandemic hit, which then now they're kind of just now reemerging in terms of how we can continue to partner. But the overall goals, I'd say, if you look at all of the pilots and the programs that we participated, have been to meet patients where they are, meaning via where they receive healthcare, and to identify processes for screening for food insecurity within clinics, and how that referral system and larger model works between healthcare systems and food banks, developing a really kind of well understood model that can be applied in different partnerships, and to increase access to and receipt of healthy foods among patients that screen positive for food insecurity, tied with nutrition education, and in turn improving and evaluating related health behaviors and outcomes. So again, I'm going to talk about a few examples. Some of our projects have been pilots that are, for example, 6 months or a year, that have had very specific goals, but in general, these are the overall aims of each of the partnerships that we've been a part of. So if you go to the next slide, I can start to get in. So I'm just going to highlight a few of the partnerships over the past 8 years to give you a sense. And then again, we're going to get into more detail on our most recent and longest term partnership. So as I mentioned, we have partnered with federally qualified health centers in the Detroit area and beyond within our service area. One is CHAS, which is Community Health and Social Services Centers. That's in Southwest Detroit. And we partnered to serve food boxes and diabetes-focused Cooking Matters nutrition education classes, and that was for patients specifically that had uncontrolled diabetes. We delivered or had patients pick up food boxes 2 times a month, so every 2 weeks. And we found that, and they had a choice of menus and that included different cultural considerations given the diverse population. This pilot had about 120 patients enrolled in the program. And we found that this food really ended up providing the majority of household food needs for these patients. We found that 75% of patients reported that their health was better after completing the program, and 95% reported eating more fruits and vegetables, so centering around the health behavior change. And overall, we did see a decrease in the availability and consumption of less healthy foods after post-program surveys versus pre, and just generally less worry about how patients were going to get their next meal or food running out by the end of the month. And this was in 2018. Wayne State was an evaluation partner as well in this project. Secondly, we worked with Covenant Community Care, another FQHC. This was supported by the Michigan Health Endowment Fund, and it focused specifically on pregnant women that screened positive for food insecurity and that were part of Covenant Community Care's overall prenatal care cohort. So the goal really was, their goals were to improve outcomes and facilitate healthy weight gain, as well as for these patients to establish healthy eating and cooking habits long-term. So in this case, Gleaners provided healthy food boxes, as well as Cooking Matters nutrition education to expectant mothers directly at their prenatal care appointments. And this was 1 food box per session over 10 sessions that each cohort participated in. So we had about 65 patients enrolled. Unfortunately, we were able to get there before COVID hit, and really we had to take a pause on the program. And what we were able to do during COVID is then pivot to providing emergency food boxes, not only to mothers in the prenatal care program, but also to other patients in general at the clinics that screen positive for food insecurity. So unfortunately, because of the pause, it's made it challenging to analyze all of the data that we have in terms of outcomes. But overall, we did see in the 65 participants an overall increase in confidence to prepare healthy meals and increase consumption of fresh fruits and vegetables. So thirdly, and the last example I'll kind of touch on is a partnership, as I mentioned. We've partnered specifically with national evidence-based chronic disease self-management programs, such as diabetes prevention program. This was a partnership with the National Kidney Foundation. Also, Wayne State was a part of this as an evaluation partner. And essentially, we provided food boxes at 20 different sessions, kind of similar to the Covenant setup, for participants in the diabetes prevention program, primarily in low-income communities. And they each received a delivery, again, for each of the 20 class sessions. We enrolled about 75 patients. and saw similar improvements as we did with the Covenant Community Care. However, this was 2018 to 2020. And again, COVID hit right kind of as we were finishing enrollment and getting into the data analysis process. But based on all of these smaller pilot partnerships, this led us to our most long-term to date and extensive, meaning formatting in a randomized control trial, piloting and then implementing on a larger scale basis with a healthcare system being Henry Ford Health System, and specifically the Center for Population Health. So we can go to the next page. And this was called Henry's Groceries for Health. It started in 2017. I'm going to talk about both phases of the program, and just recently came to an end. Phase 2 came to an end in May 2022, and we're still waiting on the final results of that second phase, but I do have results to share from the first, and just kind of overall process. But this was the logo, and this was kind of some of the verbiage that patients received when they enrolled in Henry's Groceries through clinic sites. So if you go to the next slide. So overall, what were the aims of our partnership? So we wanted to first determine just the feasibility, I would say, of food bank healthcare system partnerships, and just explore the feasibility of the processes and general collaboration, meaning referral, screening, customer service, scheduling. We also wanted to design a program based on all the learnings that we brought from the past with other healthcare partnerships, as well as from Henry Ford on addressing social determinants of health, that would overall mitigate food insecurity among vulnerable patient populations. We wanted to learn from each other. And of course, we wanted to evaluate, in this case, Henry Ford being the primary evaluator, the impact on participants' health outcomes, specifically through an IRB-approved longer-term study. So we looked at A1C in diabetes patients. We looked also at BMI, as well as emergency department and inpatient hospitalization visits as our outcomes, as well as, again, the feasibility in the process. And go to the next slide. This just gives an overview. Again, I'm going to talk specifically or separately about each phase so you can get a sense of the progression of the program. But this gives an overview of kind of both. So this program was an innovative solution to, again, mitigating food insecurity through this type of collaboration. Patients who screened positive for food insecurity were enrolled and received healthy food boxes every 2 weeks for 1 year. These were biweekly deliveries. We did have a pickup option in the pilot phase, but found that folks that did not work as well. Delivery was definitely preferred. We included, a combination of fresh, frozen, and shelf stable foods and foods in all major food groups. And we in phase 1, Henry Ford kind of handled the the customer service and the scheduling role, and that flipped to Gleaners in phase 2. And we also provided healthy recipe cards and a letter from a registered dietitian included with the food deliveries as kind of an extra support resource. You can go to the next page. And actually, I'm gonna flip this order a little bit. If you can go to the next one, and then I'll have you circle back to this page to give a sense. So going into phase 1. So this phase was our pilot phase, started in 2017. And this was, so eligibility criteria, you had to be an adult, so 18 or older, participating or in a patient at 3 participating Henry Ford clinics in Wayne County, but that also in Detroit, and that also expanded to some areas of Macomb, Oakland, and Wayne counties. So in this first pilot, patients who were under 18 who did not screen positive for food insecurity with our 2-question screener, if they were unable to consent, or if they had a household over the size of 3. So we started with smaller households to really learn how it went and learn about the process. And we also, so those folks were not eligible to participate in this first pilot phase. Also, if they had restricted diets like food allergies, or if they were on dialysis, this first phase, we were not able to accommodate that with our food box menus. So we enrolled in this pilot phase about 340 participants. There was an intervention and a historical control group that was determined. And so what did we see as the value of this phase? So almost all the respondents indicated that the food they received met their needs, and that they consumed almost all of the food that they received, which we're always looking at, waste management. So that was great to see. We found that about half of the patients utilized the recipes that were provided in the boxes. And here, in terms of health outcomes, we did see a significant within-group reduction. So within the intervention group, there was a reduction of 42% from the year prior to the year during the intervention of emergency department visits. There was also a reduction in the control group, but less so at 25%. We also saw a reduction, and again, significant within group, among those in the intervention group for inpatient hospitalization. So we saw significant outcomes around healthcare utilization. The A1C and BMI outcomes were not significant, although very close to for A1C reductions. We did see a substantial reduction, improvement in A1C and also BMI. We were able to establish an effective screening and referral process, and establish the feasibility of this type of partnership through this study. We go to the next slide. So phase 2, the kind of just differences to point out. So this really expanded our efforts beyond a pilot phase to patients at 5 clinics. We enrolled just over 1,000, and this also included both pediatric and adults facing food insecurity. We also were able to accommodate smaller families, as in the first pilot, as well as family size, which we had, I think, 3 to 5 people in the household, and then larger family households. So we had 3 different sizes of boxes. We are also able to enroll those with different dietary restrictions, as we had options for halal, vegetarian, and, for example, kidney disease friendly box accommodations. So we saw similar value in phase 2. Again, we are still waiting on those final analyses to come through, and we hope to move forward with submitting for publication. But we also have seen evidence for preliminary results of reduction in healthcare utilization among these patients as well, and similar around the utilization of the food received and use of healthy recipes and other resources. Next slide. So I included this slide just to kind of step back after the overview of each of the phases, and just share some insights on our learnings around key decisions that we found extremely important for the success of our partnership. So one is team building, just really having a clear communication plan, who's going to lead regular meetings, meeting more regularly in the beginning of the project, and really having daily touch bases was extremely helpful in just getting the screening and referral customer service process down. Designing the model. So we used a delivery model, but there was a lot of conversation on whether a food pharmacy model, a voucher system, having a pantry available at a hospital or clinic. Those were other examples of delivery models, considering what specific population you want to serve. And really a lot of focus on workflow. So what is that going to look like? Who's going to manage the evaluation process, creating a timeline for the evaluation and really sticking to that timeline, developing really quality patient communication was something that was super important. So I'd say that those were just really key areas to consider if you are considering or currently in this type of partnership. Next slide. Almost at the end here. So overall, I'd say that some major successes were just really adding a lot of evidence towards the value, and this is not only Henry's Groceries, but with outcomes from our other partnerships, adding evidence to highlight how valuable food bank healthcare partnerships can be in directly addressing food insecurity as a key social determinant of health. We developed a service model that focused around delivery in this case, for providing healthy supplemental meals and education to patients in need. And we showed improved outcomes. Although I do want to say, as a, just another bullet point under that success, that is an area moving forward that, given challenges that we faced during COVID with data analysis and the time it takes to complete data analysis, we really would like to move forward in focusing more on health outcome related data. So what impact are we having, not only in utilization, which is the one that we've been able to focus on most, but having a higher sample size around the impact on A1C levels of this type of programming and partnership, as well as other specific areas of chronic disease management. Challenges, I'd say, as I'm sure many of you know very well, implementing screening, any additional screenings, if they're not already in place in busy clinic settings, can be challenging, and just in getting everyone on board and having a smooth process to make sure that everyone is screened. We found that enrolling pediatric patients can be more difficult than adults, just depending on the age of the child and who's there at the time of the clinic visit. Stigma and maybe not wanting to report in front of children. So we found that more challenging. Securing funding, as always, for longer term impact, which is really the direction that we want to be able to take this in. And I think that the kind of immediate world around food bank healthcare partnerships, the direction we're looking to go in, but it's challenging to find something larger than a small pocket of funding. And as I mentioned, in several of our projects, scientific analyses can take time. So it's just important to build in that piece and keep on a timeline and a pace that really works for understanding the impact of your program. And last slide, I believe. So in terms of moving forward, Gleaners, as I mentioned already, is looking to secure longer term funding to implement the model that we know is best practice. So that includes healthy food boxes with several cultural and health adaptations available, inclusion of nutrition education, and the evaluation piece. We would love to be able to do this over more than a couple years. We are currently continuing to work with Henry Ford on the next step of Henry's Groceries, and also in several conversations with other health systems and Medicaid managed care organizations to kind of find that right fit where we know we're going to be able to serve even more patients than we have in the past through our projects, and that has hopefully some more built-in sustainability and support. We want to further understand specific impact for specific chronic diseases and overall health outcomes, continue to share our results, and participate in that advocacy piece to get to this gold star place that we all want to get to, that some states are further along than we are, to have regular reimbursement from Medicaid and or Medicare for food boxes and access to healthy food, so that the issue of sustainability and these pockets of funding that can cause challenges for ramping up and ramping down, for example, takes a lot. So it would be great if we were able to kind of have this more built in as a policy. And again, we work with the Food Bank Council of Michigan and others that are very integrally involved in the policy space to advocate for this step moving forward, which of course takes time. But yeah, so I would love to open up for questions. And I know I shared a lot of information, and but there's a lot more out there. So I did link one of our peer-reviewed publications for phase 1 of Henry's Groceries in that phase 1 slide. And there's definitely, further information around other partnerships that I would be happy to share either, within Q&A session today or offline with anyone that's interested. But thank you.
Awesome. Thank you so much. Does anyone have any questions for Jessica? I have a question for you.
Yeah.
Kind of regarding the, I guess, final phases of when you were doing the implementation phases of these programs. So when you're kind of concluding the implementation phase, do you provide the individuals with any like long-term resources of like, here's what to do moving forward when you're not as intricately involved with, their food access?
Great question. Yes, and that's a very important piece that we link any participant or patient in these partnerships and just in general with resources like, for example, pantrynet.org, which you can link to on our website, that has all of our distributions, and you can put in your zip code and find the closest one to you, or the closest distributions, plural, to you, to kind of in the hopes that people can start to, outside of these partnerships or programs, link themselves more into a regular system of food distributions. And we also provide them with information on other resources in the area. So for example, Food Gatherers, some may be familiar with, also has programming and access to food. And we have a SNAP outreach program. So we also provide patients with information on SNAP benefits, whether they might be eligible, and link them with assistance that they can call directly to complete applications if they're unable to. So we do really try to create that sustainability within our programming through some of the other very stable ongoing programming that we have.
Awesome. Thank you.
My name is Karen. I have a question. Can you hear me okay?
Yes. Hi, Karen.
Based on your distribution of your food boxes by the delivery model, did you have a radius that you would work with? I mean, if I was a patient at a particular clinic, but I lived 40 miles away from the clinic, I'm sure you wasn't coming to my house.
Well, I guess we did oftentimes, some of the pilot projects had more specific radius than others. But actually, within most of the partnerships that we've had, we've been able to deliver within our service area. So that's 5 different counties. And within, like the second phase of Henry's Groceries, we expanded to more than just the 3 counties that were included in those 3 clinics, and were able to deliver outside of that as long as it was within Gleaner service area. So, but some other pilots, and I don't remember exactly what the radius was in terms of mileage, did have more restrictions. If we had, for example, just based on for the delivery fees, which of course can be expensive, or logistics within scheduling, but by and large, we try to service whenever we can our full service area.
Thank you.
And that's either, and we have at Gleaners a robust delivery system in place with our mobile distributions and kind of the ability to hire drivers and do that piece. We've also contracted with other delivery or driver systems. For example, we've recently had a partnership with DoorDash, and sometimes when we contract, and sometimes internally as well, but more so when we're contracting, there might be more limitations built in given the higher cost.
Great. We do have a question that came through the chat from Brittany. Her microphone's not working, but how often are you screening and asking patients for data, specifically with regard to how your program improved health outcomes and kept people out of the emergency department?
Yeah, so depending on the project, with Henry's Groceries, we had monthly process check-in, so quicker surveys on kind of receipt of the food, how did they use the food. Those happen on a monthly basis, and then the more substantial, so we had a baseline survey, and then in the case of Henry's Groceries, another longer survey at 12 months. So in smaller pilots where there were less time, for example, there were a few that were 6 months. So, the kind of the major indicators were like A1C, for example, with CHAS, it was before the program started, and then at 6 months. Where the survey sent out via email. So in some cases, yes, in some we did them all on paper. So it depended on on paper, meaning we called and had someone implement the survey if they in some cases, and then in others we were able to send out via email or by QR code.
So my name is Jessica.
Hi, great name.
Hi. we must have smart parents, right?
Yes, clearly.
But my question is related to the communication that was between you guys as the community organization and then the health system or the clinic.
Mm-hmm.
One of the broken areas for me when I refer patients out to a food resource or something like that is I never hear back unless the patient comes back to see me in 6 weeks or 3 months, and then, oh well, no, I couldn't get through to them or whatever. So I'm interested in how you're navigating that communication piece between the community provider and the health system.
Yeah, and you mean specifically getting a hold of the patient as well, kind of in that.
Yeah, like how do we close that loop?
Yes.
Yeah.
So I know, and from these partnerships as well as in previous work and in similar types of partnerships, I think, so what's really important and what we had in Henry's Groceries and in others is a dedicated, who's ever handling the customer service and the scheduling piece, there are dedicated staff funded by this project or dedicated to this partnership to handle the communication. And that is with the health system, and that's also with the patient. So I think that's key, because if you don't have someone dedicated to that specific role, which of course can be, there's resource challenges and everything with that, but ideally that is what we have found, that do not underestimate the effort and time that it can take for the communication process to be clear and to reach patients as well, especially, if you also tie in from the food bank side of things and reaching out to patients, or even who's ever reaching out to the patients, it can take 5 to 10 times sometimes to get a hold of someone and be able to check in with them or whatever the case may be. So I think, again, having a really consistent, dedicated person to that work has been a key in mitigating some of the challenges that come with it. Because I think I totally understand what you're saying. Like if it's not within, if you don't have kind of a specific go-to person or people, and it's kind of wrapped in with the general day-to-day and tied in with, you know, all the other programming going on that every customer service person at a food bank is responsible for, then there's greater risk, I think, of having that situation where someone reaches out and it doesn't go anywhere, they don't hear back. Now, I would hope that any client, I mean, we strive to not leave people, I mean, emails come through all the time, calls come through all the time, and we, you know, our customer service team is there to help people navigate through. So I hope that wouldn't happen in general, but I think that it's more likely to have delays when you don't have someone that's dedicated to that communication role. So in Henry's Groceries, again, first phase one, it was the healthcare system or Henry Ford, who had dedicated staff for that patient communication and communication with the food bank piece. We also had staff on our end that were, of course, dedicated to the communication and the day-to-day around the specific project. And then in phase two, it all flipped over to Gleaners. So we were handling the customer service, the scheduling, the calling patients to follow up, and also the communication with Henry Ford staff dedicated to the project.
So just as a follow-up, I'm assuming because they were different demonstration projects that the patients had like an informed consent or some type of thing to participate. Yes. But what about, you know, outside of a demonstration project? Do I, you know, it's tricky. Do I have to have a release of information in order to speak with the community partner about my patient, or, you know, those kinds of things? Are you thinking ahead to navigating some of those types of challenges?
Yeah, and those communications, so we have, and I can't speak specifically again to every project over the last 8 years, but there's always been an official agreement or MOU, even if it's not an IRB, if a study hasn't gone through the IRB, which in many cases we have had that given who our evaluation partner has been, but in cases outside of that, we've had that built into the agreement where we can have that communication through our contract. And if there's any other associated paperwork around data sharing or things of that nature, then we've created amendments and second, you know, kind of secondary contracts around data and patient information and identifying. So I would say, yes, we have, you know, we've had different ways of navigating that within different projects, and it really kind of depends on who the partner is. And I think moving forward, you know, that's always a big piece of the process in any new partnership, for example, and looking out which of the ways that we've done this is going to work this time, because every organization that you work with could have, you know, a different expectation around paperwork that needs to be completed for that purpose.
Thank you.
Mm-hmm.
I have one quick follow-up question just regarding what you had said with like follow-up calls. Did you find that the patients that you were serving was were a majority of them English speaking, or did you have any others that spoke a different primary language that you had to navigate, and how did you go about that?
Yeah, primarily English speaking. I know that we in some studies though, we had populations that were Spanish speaking, and so we had staff that were dedicated that spoke Spanish. And typically on our programs team and other teams as well at Gleaners, for example, we have full-time staff that speak Spanish as well as Arabic. Those are the two, and or, you know, including English, those three languages are the ones that come up the most. So we know that we need to have kind of the built-in availability of speaking those languages for patients. So I know that was a part of some of the partnerships that we've had.
Great, thank you. Does anyone have any other questions?
Sorry, one other question. Will you be releasing your slides to can you send those out on email? I think I missed the first couple.
Yes, definitely. We'll be sending out Jessica's slides in our email following up the presentation.
And if you have more questions or want to talk specifically separately about any aspect of what I mentioned, please feel free to reach out. I'm happy to set up a meeting and talk, and either my email or my phone number is there as well. I'd love to talk to you.
Wonderful. If we don't have any other questions, I can finish up the last few things of our work group. I just have a few concluding slides for us. So thank you again, Jessica, for being here with us today. That was a great presentation.
Thank you all so much for having me. It was great.
Wonderful. So before we conclude, I just want to review a few upcoming events that we have. So we do have a Health in Action work group on May 11th. And in recognition of Mental Health Awareness Month, this work group will highlight the work of the Michigan Collaborative Care Implementation Support Team, which partners with health systems across the state to provide individualized consultation and specialist training in the implementation of the collaborative care model. Additionally, I did want to make a note that our spring collaborative-wide meeting will be on May 19th from 10 to 3 p.m. at the Vista Tech Center in Livonia, Michigan. This is an in-person event. This spring's meeting will focus on interdisciplinary collaboration, care transitions, alternative sites of care, and success stories from MVC's 10 years of partnership with healthcare providers. At the collaborative-wide meeting, we also will organize a poster session to feature success stories from the last decade, as well as the quality improvement initiatives that are happening within our member hospital and physician organizations. So we do encourage you to submit a poster highlighting any quality improvement work that you're doing or any impact stories that you may have. And we kindly ask that you submit those posters to our email address by May 5th if you're interested in participating. Lastly, we have a diabetes work group scheduled for May 23rd from 2 o'clock to 3 o'clock p.m. And that will feature Sparrow Health System and Sparrow Eaton Hospital and focus on their diabetes education programs. So with that, thank you again for joining us today for this work group. We appreciate everyone coming and asking questions. Additionally, moving forward, if you or someone you know may be interested in speaking at an upcoming work group, please feel free to contact the MVC engagement team via the email listed on the slide here. And, thank you again for your support of MVC, and we look forward to seeing you at future work groups. Have a great day, everyone.